Hi, I'm Ed Stiles. I'm professor of osteopathic principles at Pikeville College, and today we're going to be talking about indirect techniques and doing it from a perspective of the history. But what I want to stress is the principles behind the techniques more than the techniques. And also I want to stress is we're tapping into the same self-healing potential mechanisms in the body that A.T. Still was tapping into. And what we'll be doing is talking about a little bit about the history. Then we'll talk about the indications, give you some examples of the different ways these principles can be applied. Now, here are the objectives today. We're not going to go through each one of those because we just don't have time. Now, there are two basic myths concerning osteopathic manipulation. One is that the functional part is out of place. But if you look at these slides of the vertebra, ribs, and the sacrum, they're dense ligamentous structures. And obviously, those structures do not get out of place. And a better analogy is that the dysfunction is like a door that's restricted, and therefore it can't completely open or close. But it's not out of place. The second myth is that a lot of force is required to put these dysfunctions back in place, whereas in reality, all you're doing is reestablishing normal movement. And I recently did a study up in the Northwest with some people that were using the spinoscope and surface EMGs while people were on treadmills, and we treated them before and after. And we were able to demonstrate that small mechanical changes can produce huge neurophysiological changes. And this is where we're going with functional OMT. We're just making minute changes, but what we're doing is trying to reestablish normal mechanics so the door can appropriately open and close. Now, what's the basis of the classification of direct and indirect techniques? Now, a schematic for a normal joint could be as the following. You have an anatomical barrier, which means the shape of the joint determines what movement potential that joint has. You also have elastic barriers, which are made up of the ligaments, the tendons, and capsules, and they're going to restrict the movement a little bit of the anatomical shape of the joint. Then you have physiological barriers that are made up of the muscles and fascia. And so you have all three of these components in the joints of the body. Now, active range of motion is between the physiological barriers because the muscles are introducing the movement. But when the muscles are relaxed, the range of motion is greater with passive motion testing because the muscles are relaxed, and now you can get closer to the elastic barriers. And it's important when you're evaluating patients to, many times when you find the dysfunctional area, evaluate it both actively and passively to get a true picture, because many times a dysfunctional area will be compensated for by the segments above and below. An active range of motion may appear normal, but when you check it passively, then you find there's a dysfunctional area within that region. So this would be the schematic for the normal. Well, what is somatic dysfunction all about? Now we've got a restrictive barrier, so it's not out of place, but we've got this restrictive barrier, and now active and passive range of motion are both restricted. It'd be normal in this case to the left, but it's going to be restricted going to the right. And so the restrictive barrier would represent the lost range of motion, both active and passively. And this whole concept of barriers was developed by Paul Kimberly and is a very useful tool in explaining manipulative technique. Now, when we treat somebody directly, we're going directly against the restrictive barrier and trying to challenge that barrier and to eliminate that barrier. Whereas indirect techniques, you're going away from the restrictive barrier and trying to change the restrictive barrier with an indirect strategy. So again, it's not out of place. And a great analogy is if you have a drawer stuck in a little chest here, that you've got several options. You can pull the drawer out or get in behind it and push it out. Those would be direct techniques. You're going against the barrier. Or you can slide that drawer in, jiggle it until the contents settle, and then slide it out, and that would be the example of a indirect technique. Now, what are the criteria for manipulative techniques? And Fred Mitchell Sr. came up with this model, and it's beautiful because you can evaluate any technique that you see being used by any clinician and understand what's going on. If you look at two criteria, and the first criteria is what are they doing with the whatever they're treating, a vertebra, a rib, a sacrum, a radial head. What are they doing in relationship to the restrictive barrier? And the second is, what is the corrective force that's being utilized to correct that dysfunction? So with direct techniques, you're going directly against what many say the feather edge, or you're just nudging it up against that restrictive barrier. Then if you use a physician-introduced force, it would be called high velocity. If the patient uses a muscle effort, then it would be called muscle energy technique, or MET. The indirect techniques, you're going away from the restrictive barrier, and this would be the functional techniques, strain, counter strain, facilitated positional release, balanced ligamentous tension techniques. These are all part of the classification of indirect techniques. Now, the corrective force is, like we said, if the physician introduces as the Europeans say, an impulse or a thrusting force, then it would be called high velocity, low amplitude techniques. If the patient makes a muscle effort and you're basically functionally changing the origin and insertion of the muscle, and now you can get that muscle to introduce movement into that dysfunctional joint. The third is if you go indirectly away from the barrier and hold it in that position, then the body realizes that's a safe position for that dysfunction to be in, and the tissues can start to relax, the neurophysiology can start to change, and normal mechanics can be restored to that joint. So you've got multiple approaches. So the two things you look at is, what are they doing in relationship to the restrictive barrier, going directly against it or indirectly away from it, and what is the force introduced? And if you look at those two things, you can watch any clinician and you can figure out the technique they're using. Now, with indirect techniques, the starting point for all the techniques is basically the same. So what happens is, with the restrictive barrier, the vertebra in this case can normally rotate to the left. It's restricted going to the right. In a normal joint, you have a neutral point, which would be about halfway in the middle. And when you're at that point, that joint is the most relaxed. Now we have a new neutral, and when I learned the functional techniques, nobody was publishing articles on this stuff. And what I found is when you hit that point, immediately things started to change and started to correct. So I came up with the term dynamic balance point. Now, the Jones people, strain, counter strain, they'd called it the mobile point. Dynamic neutral was a term that Bill Johnson used with functional methods. Fryette neutral is the one that Shiowitz uses for facilitated positional release. But when you work with those clinicians and palpate the vertebra or whatever they're treating, as they do it, we're basically all at the same point, just little different names. Now, when that's treated, then all of a sudden, with an indirect, the barrier disappears, and now motion to the right and left is normal. And it'll be equal going in both directions. So what you've done is you haven't put it back in place. You've just reestablished the normal mechanics using the neurophysiological principles of indirect techniques. Now, the indirect techniques are very interesting because Still used them. And his early followers used these techniques. But what they found was they were difficult to teach and difficult for students to learn. And therefore, many people believe that's when the high velocity techniques came into the picture. But there were several groups, Sutherland, the Lippincotts, Becker, and Wales. They all kept working with the indirect techniques because Sutherland had been a student of Still, and he kept this movement going, and then his followers, Becker and Wales and the Lippincotts, they kept talking about these indirect techniques, but they were not taught in the osteopathic schools. In the late 50s and during the 60s, Three groups refocused on indirect techniques. Hoover on the West Coast, Johnson, Bowles, and Goodrich on the East Coast. And it's interesting because Charles Bowles was a student of Norbert Wiener at MIT before he went into osteopathic medicine. And Wiener was developing his concept of cybernetics or feedback loops. So this would make sense that the people on the East Coast were looking at functional techniques because they saw them as an example of a cybernetic system. Then in Kirksville, George Laughlin was using indirect techniques, and he was a grandson of A.T. Still. Now, The Lengthening Shadow of A.T. Still was written by Hildreth, and look at this quote. It was difficult to follow his hands, A.T. Still's hands, in some of his diagnoses and treatments. There was no hesitation, for he had a clear picture in his mind of the structures he was working with. None of us had as much knowledge, and no one matched his success or his techniques. His instructions and technique were often over our heads, but his reasoning, his deductions, and his philosophy were of greatest value. See, and this is the problem they had in the early days of the profession, because Still was getting unbelievable results, but he didn't have the language and concepts to actually describe what he was doing, so it was a problem. Now, my history in this and how I got interested in it, as a student in Kirksville in 1962, I was part of a study group that went to various faculty members and asked them to help us better understand what OMT was about. And someone finally introduced us to George Laughlin. Like I said, he didn't teach at the school. You could go through Kirksville and never meet him. He mentored me until he died in 1981 and had a profound impact on my career. He learned this approach from Sutherland because George was 5 when his grandfather died. He didn't remember his grandfather at all. But years later, Sutherland taught him what his grandfather did. It totally changed George's practice style, and he used that approach for the rest of his career. The good news was that he learned these techniques. The bad news was he couldn't verbalize what he did. And so all as I was able to do is watch him practice, and he demonstrated great skill and amazing clinical results. I discovered if I mimicked some of his techniques, I often got some great but very inconsistent clinical outcomes. And like I said, George didn't teach at the school, and few students ever were exposed to his practice style. In 1989, Phil Greenman forced me to teach a functional course at Michigan State as part of the postgraduate CME programs. And being forced to organize George's material turned out to be a blessing in disguise because it enabled me to be able to verbalize these techniques, and also I realized a quantum jump in both my clinical outcomes and my consistency once I was forced to verbalize the materials. 9 years later, when I came to Pikeville to be the first chair of OPP, I discovered functional techniques could easily be taught to first and second year students. And what enabled that unexpected teaching outcome? Two things had developed since 1962 when I first met George. The muscle energy diagnostic system was available, and the barrier concept was available. And up until this time, all the indirect techniques were basically taught by people that said, here's a problem, and here's what I do to correct it. And people weren't too sure there was a problem. They weren't too sure it was corrected. And once we used the precise muscle energy diagnostic system and then used a functional technique and went back and rechecked it with a muscle energy diagnostic approach, we found that it was you could confirm that you had made a change. And then when you just said, now you're going away from the barrier, it was easy for students to pick up these principles. But this was not available in '62 when I was first met and worked with George. Now, what are the benefits of indirect techniques? One of the great benefits is you don't need a table, because you can treat basically everything in the body with the patient in the sitting position. So it makes it nice. If you're visiting someone and they're having back pain, you can have them sit in a chair where they straddle the chair so that the front of their body is facing the back of the chair, and you can treat them in a sitting position using functional techniques. So it's a real advantage that you're not restricted if you don't have an appropriate treating table. There's a wide variety of clinical indications for it. Real acute patients do very well with functional techniques. Complicated and chronic patients and problems do well. They're beautiful techniques because you can also do them with the patient in the supine position, and so they're great for hospitalized patients and for treating patients in the intensive care unit. They're great for labor patients, and I'm going to demonstrate some techniques of treating the sacrum, the innominate, and the lumbar area with them in the sitting position, and we'll do that as part of the demonstration. They're great, like I said, with acute low back, because many times people with an acute low back problem also have a disc problem, and many times it's hard to differentiate whether the disc is producing the pain and generating the pain or the altered mechanics. And doing a functional technique puts very little stress into the system. You're not putting any more movement into that area than they did walking into your office or getting into the examining position. And if you just hold them in that position and the tissues start to relax, then you usually know that it's a mechanical etiology of the pain generator. Whereas if the muscles tighten up more and more as you get into that dynamic balance point, then you can be pretty assured that the disc is a problem. So these techniques can also be used as a differential diagnostic tool. They're great techniques with newborns and infants, and you can sit down, hold the baby's head with one hand, put their butt on your lap, and then with your hand you can palpate along the back, and when you find an area of dysfunction, just position the baby to quiet that down and get all the most tissue relaxation you can in that area. Just hold it there, and over a time of about 90 seconds it corrects, and what you'll notice is that's the time that Larry Jones talked about strain counter strain. So you can use these techniques for newborns and infants. They're also great with people that are under a lot of stress or have high allostatic loads, because these people feel they have to be in control, and they never feel like they're out of control. All you're doing is helping the body do what it can already do better, and not only do you improve their functional musculoskeletal abilities, but many times that'll also help the patient to realize that that'll help to help them in the high stress situations. So the patient realizes that their body, when appropriately diagnosed and positioned, will attempt to realize its health potential. And once the patient realizes that, many times they'll say to you, what else can I do now that I realize this to help my body function better? And it gives you a great entree into start talking about lifestyle and saying to the patient, well, how about cutting back in your smoking and get some weight off and start exercising and start eating properly? So that's another benefit of the functional techniques. Now, can you really diagnose and treat these dysfunctions in the sitting position? And the answer is yes. Now, with the patient sitting, to make a sacral diagnosis, as we all know, you need to know what's going on at the sacral base, what's going on at L5, what's going on at the inferior lateral angle. You need sitting forward bending tests. You need sphinx tests. Well, these can all be done in the sitting position. So you can palpate the sacral base and ask yourself which thumb is more anterior, which is more posterior. You can then slide up and palpate L5, and is L5 doing the opposite thing that the sacrum is doing, which is represents the normal mechanics. You can palpate down to the ILA, or the inferior lateral angle of the sacrum, and which side is inferior and posterior. You can palpate the posterior superior iliac spines, have the patient bend forward and do a sitting forward bending test. And remember, the dysfunctional side will ride cephalad. You can also repalpate the sacral bases and have the patient extend backwards by pushing their stomach forward and bringing their shoulders back. And in effect, you've done a modified sphinx position. And in the normal anterior sacrum, both sides should glide anterior, whereas if you have a posterior sacral dysfunction, then naturally these findings will get worse during this modified sphinx test. So you have the possibility of getting all these landmarks evaluated and motion testing done with the patient in the sitting position. Now, once the sacrum is treated, you can then put your hands on the crests bilaterally, Put your thumbs about a thumb's breadth below the posterior superior spine. That's the level of the inferior transverse axis. Then just glide the patient forward and back, their trunk forward and back as they're sitting, until you feel all the movement at your palpating fingers at the inferior transverse axis. How you're going to know you hit that axis is you can then rotate both innominates anteriorly and posteriorly, and say if you rotate the right one anterior and the left one posteriorly, then when you go the other one, the left one goes anterior but the right one doesn't come back, you know you've got a right anteriorly rotated innominate. So they can be diagnosed and treated again in this sitting position, and this can be very helpful when you're treating a woman that's in labor, has a lot of pelvic dysfunction that can be really tightening up that pelvic floor, and so therefore they're having trouble dilating that cervix because they can't get the head through the contracted pelvic floor. Now, with the OB patient and the acute low back patient, if you think of it in terms of principles and not technique, there are three principles that you can use to treat all the sacrum, innominate, and lumbar dysfunctions, or any sacral dysfunctions, with these three criteria. The first is you look at which direction is the sacrum going to initially rotate. Remember, if they're indirect techniques, it's going to exaggerate the mechanical dysfunction. And what you're going to do is load the ischial tuberosity, or bear more weight on the ischial tuberosity that the sacrum is looking at. And these are, I'm using biomechanical changes because I found when I use these terms outside the profession, then people can buy into this a lot more if I don't use osteopathic lingo. So the next thing you're going to want to do is loose pack or float, or get as relaxed as possible, the restricted sacroiliac joint. Then the third thing is you're going to translate that patient anteriorly and posteriorly until you palpate the motion at the appropriate axis. And with the sacrum, it's going to be the middle transverse axis, which is at about the level of the posterior superior spines. Then if it's a torsion, with the patient sitting, you have the patient just slowly side bend right and left and see which one turns the middle transverse axis into the appropriate oblique axis. And you'll do that with the torsions. Then if you add a little compression into the system, it kind of jump starts it, but the biomechanical people say what you're doing is loading the fascias, and then that kicks in the self-correcting potential of the body. And this will make more sense when we demonstrate these techniques. With these three principles, one can design a specific treatment strategy for all the sacral dysfunctions, all the innominate dysfunctions, and with the innominates, you're going to use the inferior transverse axis when you translate forward and back, and with the type 2 lumbar dysfunctions. So they can all be effectively treated using these three principles that we talked about above. Whereas if you give out handouts and don't stress the principles, just give handouts about where to put your hands, side bend them 45 degrees or whatever degrees you use, students do not pick these techniques up. But if you stress those three principles that were mentioned above, then the students can pick these techniques up real quickly, and it'll make more sense when we demonstrate the techniques. Now, let's have a mental image of what's going on. So if we have a left-on-left sacral torsion, it means that sacrum is rotating to the left around the left oblique axis. Now, to treat that indirectly, we want to exaggerate that positioning. So the sacrum is looking to the left, so we're going to have side bend the patient to the left a little bit until we have more weight on the left ischial tuberosity than the right. Our right hand is going to be palpating over the crest of the innominate, and the thumb is going to be at the level of the posterior superior spine, which would be the middle transverse axis. So with your left hand up on the patient's left shoulder, you're going to side bend the patient to the left until you feel the crest lift up. When you feel that, you know you've closed packed that joint. So back off towards the right a little bit until you feel all the tension come back out. And what you've done then is you floated or loose packed that right sacroiliac joint. Then glide the trunk forward and back until you feel movement all right at your thumb at the level of the posterior superior spine. Now you know you've located the middle transverse axis. Then with that left hand up on the shoulder, slowly side bend the patient right and left and see which of those movements allows your right thumb to glide caudad. And what it means is you've just turned the middle transverse axis into the left oblique axis. And how you'll know that, you'll feel that sacral base start to glide forward as soon as you hit that point. Then you introduce the fascial load from that hand up on the left shoulder and slowly put compression in and vector it down towards the sacroiliac joint. And when you get the right amount of pressure, the body will automatically start rotating around to the left, which is taking that dysfunction into more and more left-on-left sacral torsion. Then it'll stop or hit a, for a lack of a better term, a still point. Hold the compression there. Then in a few seconds you'll feel the tension start to build up again, and the body, don't inhibit it with your compression, but allow that body then, on its own, it will start to go around to the right and gyrate to the right. And as it does that, what it does, it loose packs the right sacroiliac joint again. It automatically goes to the left oblique axis. And what now happens is the right sacral base is able to glide posteriorly. Now, here's the problem of when I was learning this from Laughlin. And like I said, he couldn't verbalize what he was doing. He would put one arm across the shoulder so that his elbow was like on the left, his left elbow was on the left shoulder, his left hand was on the right shoulder. Or he could reverse it and use the other arm. The other hand would be placed over the sacrum so that the palm of his hand was right over the sacrum. And then what he would say is take the doodad where it wants to go. Then he would say fiddle and diddle it. Add compression, and the compression could be either added in from the elbow or from the hand. And the body would then start to unwind away from the restrictive barrier to the left, hit a still point. Then it would come around and come through, and George would say, I'm done. Well, you can imagine, because in those days in osteopathic schools, high-velocity techniques were taught. Some articular techniques and soft tissues techniques were taught. All the other techniques that we know today were not available, were not on the scene. And you can imagine, I'm learning high-velocity techniques in school, then I'm going over and watching George do this. I thought for a long time he was crazy. But then patients raved about what he did, and professors that I had that knocked what Laughlin was doing ended up in his office having him treating. Then I began to realize, hey, this guy's got something. He may not be able to verbalize it, but I want to try to figure out what he's doing. And it took me 27 years to be able to verbalize it because the language and concepts weren't available at the time to do it. Because the barrier concepts and the muscle energy stuff had not been really developed at that point. So what I realized was George gave me a roadmap. And unfortunately, the map was in a language that I didn't understand. So when he said, take the doodad where it wants to go, now what I would say is he told me the position to put them in to start them at the dynamic balance point away from the restrictive barrier. Then the map showed me the way, but it didn't allow me to read the road signs and know how to interpret the road signs. So George would say fiddle and diddle. Now what we would say is loose pack the restricted joint, find the appropriate axis. If it's a torsion, turn it into an oblique axis, put compression into the restricted sacroiliac joint, and it'll unwind indirectly, hit a still point, then come out of it in a direct manner because the restrictive barriers. So now I can verbalize what George was doing in '62, but could not explain to me because he didn't have the language and the concepts weren't available at that time. Now, Bill Johnston, this is in the new issue of Foundations, and I think this helps to explain the things about taking the doodad where it wants to go and fine-tuning it. And it's the principle for the key of getting good results with all OMT techniques. Translation is moving a segment along a straight line. So if we take, say this block represents a vertebra, if we glide it backwards and along a straight line, we introduce flexion. If we glide it forward, we introduce extension. And whenever you do that, keep the dysfunctional area at the apex of the curve because then you get the maximum motion potential at that site. And because of the third law of spinal mechanics, you restrict everything above and below it. And so you're localizing your forces right to the key dysfunctional area. You're going to get a lot better results no matter what manipulative technique you use. When you translate laterally right to left, when you glided the body to the right, you're introducing side bending to left. When you translate it to the left, you're introducing side bending right. And again, keep the dysfunctional area at the apex of the curve. Then cephalad and caudad translation can be used, so that would be compression and traction. Now, then you can add on this the segmental movement. So around the x-axis, you're introducing a side bending right and side bending left. Around the y-axis, you can be introducing flexion extension. And these are small movements. Around x-axis, you can be introducing rotation right and left. So what you're doing is using translation to get the vertebra or the sacrum or the innominate in the position that you need. Then by fine-tuning the movements with flexion, extension, side bending, and rotation, you can get that even more relaxed using these principles. So translation is the key to getting good localization with any osteopathic technique. And like I said, it restricts the mechanics above and below the vertebra at the apex. And if the dysfunctional one is at the apex, then it doesn't require much force to correct that dysfunction. And whenever you're treating people using translation, always make sure you keep the center of gravity over the pelvis so the patient isn't leaning way back or way forward or to the right or left, but you want the forces over that pelvis. So these movements, taking the doodad where it wants to go, George is talking about using translatory movements. The fine-tuning, the fiddle and diddling, he was fine-tuning around those axes, and when you do that, then you're hitting the point where there's the most relaxation. Then the body says, hey, it's safe. Then it can start to self-correct. Now, let's talk about left posterior innominate using the same principle. If you rotate an innominate posteriorly or on the left or the right one anterior, the anterior part of the pelvis is looking to the left. If that's the case, which ischial tuberosity are we going to want to load then? It's going to be the left because that's the one the sacrum is looking at. Which sacroiliac joint are we going to want to relax? The left one, because the left innominate is anteriorly rotated posteriorly. It can't rotate anteriorly. Then we're going to translate the body forward and back to find the inferior transverse axis, and what I said was your thumb then is going to be at the about a thumb's breadth below the posterior superior spine. So what this is going to look like, you're going to have your right hand up on the right shoulder. You're going to slowly side bend the patient to the left until you feel the sacrum pushing the innominate down into the table. Then you back off, then with your thumb at about a thumb's breadth below the posterior superior spine, translate that whole body forward and back until you feel all the movement at the inferior transverse axis. Because it's not a torsion, you don't have to convert it into an oblique axis. Now put in your compression and do it again. Do it slowly and vector it towards the sacroiliac joint. And when you get the right amount, it's like it jump starts that body, and so it'll start rotating to the left. The whole trunk will rotate to the left, which is bringing that innominate into more and more posterior rotation on the left. It'll stop. Hold that compression there, then you'll feel the tension start to build up, and you'll feel the body want to start to go to the right. Keep the compression in, and what it'll do is it'll rotate around to the right, and what that does, it carries that right innominate, or that left innominate anteriorly, and corrects the dysfunction. So it wasn't out of place, it just couldn't rotate anteriorly. Now we've got it rotating anteriorly. Now, we can use the same principles with lumbar dysfunction. Say if someone comes in, they've got on an MRI, they've got a disc. The disc isn't huge, but some people think the disc may be the problem, but there's also a flex dysfunction at L5, so that vertebra is held like it's flexed, side bent left and rotated left. And so what it can't do is it can't side bend right, rotate right, and can't extend, and that's why the patient is forward bent and side bent and rotated to the left. Well, you don't know whether that's the pain generator or where the disc is. So here's how you can test that out. It's looking to the left, so we're going to bear more weight on the left ischial tuberosity. We're going to be palpating over the right lumbosacral area because that's the dysfunctional facet pair that won't close. So we're going to position them by having the patient slump forward. That introduces the flexion. Then side bend them left by you can use your hand over L5 and translate that to the right, which introduces side bending left. Rotate the whole trunk to the left a little bit until you feel all the tension come out of that facet pair. Just hold it there. And if you hold it there and the tissues start to relax, usually what that means is the mechanics are the pain generator. If the disc is the problem, those muscles can't relax and they'll just stay tight, and so you can use this just positioning as a differential tool. If the muscles start to relax, put a little compression in slowly again, vector it down towards that right facet pair, and the body will start to rotate to the left, hit a still point, then on its own come back and will end up side bent right, rotated right, and extended. And if that's the pain generator, the patient immediately is going to start to feel some benefit from that. If it's the disc, it's not going to. But wouldn't it be nice to get that dysfunction out before the patient has surgery? Because think about if they have a flex dysfunction in there and they fuse L5-S1 in an FRS left position, is that really going to be beneficial for that patient? So this is a great technique for acute back patients. Now, let's compare the indirect techniques. One, the positioning is the same in all of them. So it's the same position. The problem is when these techniques were developed, everybody was doing this on their own. Lots of times they weren't communicating with other people. They were just trying to figure out what was going on. And so there's a lot of names being involved here that can be confusing, but if you realize, basically they're all describing the same point. So strain, counter strain, they call it the mobile point. Facilitated positional release, they call it Fryette neutral. Balanced ligamentous tension, they call it the balanced ligamentous point. The functional methods of Johnson, he called it dynamic neutral. The term I prefer was, for the Laughlin Stiles stuff, was the dynamic balance point, because I found when you got to that point, immediately the body wanted to start self-correcting. What do you monitor during treatment? So you put them in the same position. With the Jones, the strain counter strain, you're monitoring the tender point. With a facilitated positional release, you're palpating either the superficial or deep muscles that you're focusing on. With the balanced ligamentous tension, you're monitoring the ligamentous tone bilaterally. With the functional method, you're evaluating the muscles in the three segmented unit that Johnson talked about. With Laughlin, you're talking about monitoring the short muscles around that vertebra that are maintaining that dysfunction, and also monitoring movement. Does that thing unwind when you properly position them and put the compression forces in? Now, my bias is why I prefer the Laughlin still technique approach is that as that body unwinds away from, that stimulates mechanoreceptors that haven't been being stimulated. And White in England showed in the 80s that when mechanoreceptors are stimulated, they suppress the pain receptors. So I think you get an additional bang for your buck in that not only do you reestablish normal mechanics, but you're also may be playing a big role in inhibiting pain, and in addition to just restoring the normal mechanics. And the other thing is, many people have stressed to me, they think one of the benefits of these techniques is you're treating the patient in the sitting position, you're then using gravitational forces, where basically all the other indirect techniques are utilized with the patient either in the prone or the supine position. Now, let's see, the American Academy of Osteopathy has a journal, and the fall edition had a copy of an interview by Alan Becker. And Becker was interesting in that his father was a student of Still. He became a dean at Kirksville, became a president of Des Moines. So a lot of the big names in the osteopathic profession went through the Becker home. And when Alan and his brother Roland were growing up, they met a lot of these giants. And look at what he said recently in a published interview. Dr. Still was keen on being very specific. He looked at the patient as a totality. He looked for that elusive key lesion that people have quoted for years and years. That was what Still looked for, and when he found it, he fixed it and he left it alone. He said that once done, the body will do its own work because it is designed to do its own work. To find the key restriction to homeostatic integrity, and once restoring that to normancy, to rest assured that the body will take care of the rest of the work. See, and now with all the new complex science, nonlinear, homeodynamic, anatomical, and physiological principles that are surfacing, does this really make it amazing what Still had realized, and he was way ahead of his time. Now, Becker goes on to, I heard from Father and others that Dr. Still's techniques were very specific. Much of them were what we now call functional techniques. He said popping didn't mean anything. Find out what's wrong, why it is wrong, and fix it. Dr. Ginny Chase, who was perhaps one of the last students taught by Still, told similar stories, that his treatments were indirect or functional type, that direct intervention was very infrequent, and he preferred to let the body work itself out. See, and I think that's a key point I think that we need to stress. But like I said, it was hard to teach these techniques in Still's time, and that's why the high velocity techniques came in. Now, what maintains this somatic dysfunction, or some people like the term hindrance? And why is finding the key area so important, like Still strength, according to Becker? If the patient has an injury to the musculoskeletal system, you get pain, spasm, pain, spasm, pain, spasm, and that cycle can keep going on. But researchers are now beginning to realize that, yes, that does occur, but there's a quantum jump in the difference of afferent input that goes into the cerebellum and the motor and sensory cortexes. And so I believe that what's happening, a good analogy would be the somatic dysfunction then introduces like a mechanical virus into the software program, and where it's really stored is in the cerebellum, where all the patterning occurs in the body. And so I believe that's where it's stored. It's not stored in the tissues where the dysfunction is as much. They're just reflecting what's going on in that cerebellum. And remember, the body is wired to keep its eyes level and to keep the weight evenly distributed in all four quadrants. So therefore, the whole body has to adapt. And Ingber in Harvard has talked about tensegrity. And here's a model of the skeleton in a tensegrity array. And what happens is tensegrity systems try to protect the weakest link in the system. And I believe the weakest link in the system is really the area of greatest restriction. It's the most dysfunctional area. And it's like a monkey wrench has been thrown into the gears. The gears aren't broken. They're not out of place. There's just a monkey wrench in the gears. And our job is to find the monkey wrench, take it out, and allow the body to go back to function the way it normally would. And I've seen patients who have injured an arm. The arm over the next few weeks quieted down, but then 2 or 3 weeks later they end up in your office with acute low back pain because the shoulder is adapted. That could affect the lats. That could affect shoulder or low back mechanics. They bend over and do something. Their back goes out, as they say, and you'll find all sorts of sacral dysfunctions, and you can try to treat those, and they'll improve, but they'll keep coming back because the key many times is in that arm that is totally asymptomatic and nobody has looked at it. And this may be, Jacobson was a European researcher, and just before he died, he said one of the things was he thought many of these dysfunctions and generators of pain were really a problem in the brain. And is that what he was talking about, the cerebellar stuff? And with Grotfietsky's work, like I was saying, that we found recently, that making small changes can produce huge neurophysiological changes. So find the monkey wrench in the gears and get that out. We don't have time to talk about the different mechanisms that these somatic dysfunction can produce right at this time. Now, what are the mechanisms allowing for functional techniques to be clinically effective? One is, when you get at that dynamic balance point, you shut down all the afferent input from the spindles, the Golgi receptors, the Pacinian receptors, and basically the message the body gets is it's safe in that position, so tissues can start to relax. Then as it starts to wind, that stimulates mechanoreceptors that can suppress the pain receptors. When you find that key dysfunction and treat that, it's like taking the virus out of the software, and so they're changing the mechanic or the representation in the cerebellum, and so you can get total body-wide changes once that dysfunction starts to come out, and all the adaptations secondary to it will also correct. You're also balancing up the fascias. You're balancing up the ligamentous tensions. You're shutting down all the afferent input from the extremities many times, because many times the extremities are used as part of the functional technique positioning. You're also integrating things because many times I believe you can improve the mechanics of various joints in, say, the low back region, but they're not functioning as a team. It's like a basketball team that has 5 great players, but they're not playing yet as a team. And so many times the functional techniques help all those areas to integrate into a functional unit. And like I said, that mechanical dysfunction can impact all of these mechanisms, but we don't have time to discuss that today. So the techniques you're demonstrating, are they really what A.T. Still was using at the end of his career? Now, look at the picture of George Laughlin here. Now, it's not in the exact positioning, but look at the foreheads. Look at the chin. Look at the nose. Look at the mouth. I think it sure looks like George Laughlin is related to this man, that he's his grandson. Now, Foundations just came out with the 3rd edition. On page 850, the Van Buskirk, who wrote the chapters, said, "Finally, there is the Still-Laughlin techniques, preserved and taught by Stiles. It is hypothesized that this advanced method was developed by Still towards the end of his life. It is much the same as the Still techniques that Van Buskirk takes, except what Van Buskirk does, he puts them in the original positioning away from the restrictive barrier, but then he actively brings them back through the restrictive barrier, I think Laughlin, what he did is let the body do that on its own, and I'd rather let the body do it on its own in its own timing and its own way. But requires additional identification of the key lesion in the area of greatest restriction. It is an incredibly effective method, but requires a high degree of anatomical knowledge, diagnostic ability, kinesthetic appreciation, and intense concentration." Van Buskirk is giving me way too much credit there, because if that's true if you teach it as a technique, but if you teach it as principles, that is no longer true. As such, it's not considered a technique that's easily mastered, and I disagree with that statement, because the first-year students at Pikeville in the first 6 years, most of them picked up these techniques and mastered them. But the key was finding the key area. That's the key to success with these techniques. Now, functional techniques are difficult to teach. Really? About 6 years ago, I was teaching a functional Laughlin Still course in Indianapolis. On Sunday morning, after 2 days of the course, a DO in his 80s stood up and asked me if he could say something. He stated, "My father attended ASO, the American School of Osteopathy, when Dr. Still was actively teaching. My father used some of the same gentle techniques and profound techniques, or used some of the most profound and gentle techniques I've ever seen. Unfortunately, he was unable to teach me those techniques. This weekend," and he said with tears in his eyes, "you taught me what my daddy did. Thank you." See, and that would tend to support what Van Buskirk is saying, is these were probably the techniques that Still was using at the end of his career. Now, one last quote. McConnell was a student of Still. He was the 8th president of the AOA. Look what he wrote in an AOA journal in 1931. "Precision of method follows definitiveness of diagnosis." So without a good diagnosis, you can't get these techniques to work. "It is evident that there are many ways of applying the same mechanical principles." See, and I think that's why Still never wrote a technique manual. He wanted the people to learn the philosophy, the principles, the concepts, and then they could apply them in a multitude of ways. And he didn't want people just to mimic what he did. But ease and effectiveness should be the goal of the operative activity or the technique. In adjusting lesions, it is obvious that the method which retraces the path of the lesion with minimal irritation is highly desirable. Is that an accurate representation of what we presented today? Now look at Kelvin and Hobbes. What a ripoff. They say that if you connect the dots, you get a picture. But look, I did it, and it's just a big mess. I think you're supposed to connect the dots in the order that they're numbered. Oh. Everything has got to have rules, rules, rules. See, and is that why sequencing and finding the area of greatest restriction is so important? And that was crucial to Still's success. Now, the second picture on the left is a tensegrity model on the maul. The right picture is looking up at that from the bottom. tensegrity models are very flexible and adaptable, and they it's a perfect example of structure and function. But that whole system will try to protect the weakest link in the system. See, and I think the weakest link is the area of greatest restriction. So that's why it's so important to find it. And many times a dysfunction in the rib cage can be the key producer of low back pain because it can alter abdominal tone, quadratus lumborum tone, alter pelvic mechanics, and you won't help that low back patient until you get that rib cage mechanically working right. Now, we think this is the approach that's still used, and is this quote that we originally used saying that these techniques are hard and the people couldn't match the success. I would maintain now we have the language and the skills to be able to do that. So in summary, these are very effective techniques. They can enable quick results. And think, what was one of Stiles' nicknames? The lightning bone setter. They can easily be taught if principles are stressed, not techniques. The first-year students at Pikeville loved them because they weren't afraid of hurting people using these techniques. They have a wide spectrum of indications. You don't need a treatment table, and these same principles can be used anywhere in the body.
Okay. So you can imagine that as a first-year student in Kirksville in 61, 62, and just being taught basically high-velocity techniques, and lots of times there was a lot of force being used. And then I'd go across the street and watch Laughlin in his office do what we jokingly called his voodoo Ouija board manipulation. And it took me for a long time to realize that this guy, I thought he was crazy for a long time. And the patients were crazy. But then I realized that patients were coming from all over the Midwest and realized, hey, this guy's really got something. I've got to learn how to try to figure out how to explain this stuff. Now, if we have a posteriorly rotated innominate, so it'll rotate posteriorly, it won't rotate anteriorly. Again, it's not out of place. So if it's like the pelvis is rotated back on the right, and that's turning the pelvis to the left, so that with the three principles that we stressed, we're going to want to load the left ischial tuberosity. So again, I'm going to put my hand on the crest, put my thumb at the posterior superior spine, and then go a thumb below that because with an innominate technique, I'm going to be using the inferior transverse axis because that's the sacral axis that the innominates rotate on. So we have the patient sit up good and straight. John, sit up good and straight for me. We're going to side bend them to the left until I feel the sacrum pushing the innominate down. That means I've close packed it. Back off, and when I get right to that point, I can feel the tension come out of the tissues under my hands on the crest and my thumb at the posterior iliac joint. So now I know I've got that loose packed or relaxed or floated. Then I can just glide him forward and back until I feel movement right at the thumb. Now I've got the inferior transverse axis. Then if I just take with this hand and put compression down towards that left sacroiliac joint, and when you get the right amount of pressure in, it'll rotate around to the left. It'll hit a still point, and then on its own, it'll come back out. And as it goes around to the right, that's what rotates the innominate anteriorly. So you can treat all the sacral dysfunctions, all the innominate dysfunctions. The unilateral sacral dysfunctions you can treat using these principles. Now, like we said, if we have L5, and let's in this case, well, we can do it this way. I'll get out of the way of the camera. If I'm going to do an L5, John, just turn just this way just a little bit. There we go. That's going to work. Okay. If I palpate L5, and again, where do you put your hands? Which is the dysfunctional facet pair? If it's flex, side bent, rotated left, it's the right pair of facets that won't close, then that's where I want to palpate, because around that I'm going to be able to monitor the short restrictors that are maintaining it, and is motion occurring in that facet pair. And then let the patient do most of the positioning. Say the patient's slumped down. See, and that introduces flexion and using translation, and then translate that till you get that at the apex of the curve again. When you side bend them, you can use this hand to translate a little bit and to the right and rotate to the left. So now every little movement I make, I feel it right at that facet pair that's dysfunctional. Then slowly put my compression in. When I get the right amount, he'll come around to the right. It'll hit a still point, and then on his own, he'll come around to the left, and he'll end up in extension, side bending, rotation right, which it means the barrier has been eliminated, It's not out of place. We're just getting full range of motion in that now. And like I said, and if that's a real acute low back, you can see you're not putting a lot of force into that area. You're not putting a lot of motion. And even though they have a hot disc, you can do that. And many times they've got two things. They've got a disc problem and a mechanical problem from the injury. And if you get the mechanical out before they have the surgery, would that increase the surgical outcomes compared to the people that have surgery and the mechanical dysfunction is still present after the surgery? Now, these principles can be used in any area of the body. Let's have you turn this way just a second. Let's do just to illustrate that. Say you have a radial head dysfunction and you find it won't pronate. You can just supinate as you palpate over the radial head till you feel the most relaxed position. Then fine tune till you get that even more relaxed. You can put a little compression into it, and what it'll do is it'll supinate more, it'll stop, and then all of a sudden on its own, it'll just pronate in. So you can do that with ribs. You can do it with the, let's have you turn around again with your back towards me, so your kitty corner again. Say, to show the correlation with the other techniques, with strain counterstrain, if you have a cervical dysfunction, say it's C5, and if at C5 the diagnosis is an AC5, all the anterior dysfunctions mean they're flexed. All the posterior ones mean they're extended. And the formula for treating that would be flex them, side bend them away from the tender point, and rotate away from the tender point. What position do you have them in? They're flexed, side bent, rotated left. And what you'll find is the tender point will always be over the facet pair that's open, whether they're functional or dysfunctional. Then that way the students don't have to memorize where all the tender points are. If they understand the mechanics, then they can understand where the tender points are. With the ribs, anterior ribs are expired ribs. Posterior ribs are inspired ribs. And the tender point is over the part of the rib that glides caudad. So if the front of the rib goes down in exhalation, you're going to find anterior rib points. If the ribs are caught in inspiration, the posterior end's gliding down, you're going to find posterior tender points. So that way you don't have to memorize all these tender points. If the students understand the principles, then and you'll see that the positioning for those two techniques was exactly the same. So I hope that the discussion today has been helpful, because the main thing that I'm trying to stress is learn the principles of the mechanics, and then there's a multitude of ways of applying them. So remember that we're tapping into the same mechanism that AT still tapped into. So if you have any further questions or have any comments, I'd be glad to discuss those with you. The contact points and information will be provided to you. Thank you and have a good day.